Okay, my name's Solomon Spiegel. I'm the Interventional Cardiology Fellow at Texas Tech University. I'd like to thank the moderators and the meeting organizers for having me for this. So I'm here to present an uncommon cause of hypotension during CSI atherectomy. I'm hoping we can have a little fun with this as well. So we had a patient come in, complained of chest pain, troponin was elevated. It was a 76-year-old male. He was having typical chest pain, improved slightly with nitroglycerin. I had to present to an outside emergency center, but left AMA 2 days prior. And then he had kind of a questionable history of atrial fibrillation. Home medications, as you see, had a history of high blood pressure, COPD, dyslipidemia, was a type 2 diabetic. He was an alcohol abuser, 6-pack of beers daily, has been smoking half a pack a day for 40 to 50 years. On exam, vital signs generally stable. His heart rate was a little bit quick. His exam was consistent with atrial fibrillation. In terms of his objective, a little bit anemic. White blood cell count was acceptable. Kidney function okay. LDL not quite under control. BNP was elevated, and we used high sensitivity troponin, which is 381. So ECG. Pretty much just atrial fibrillation, maybe some lack of anterior forces. His chest x-ray, he had bilateral pulmonary edema, right-sided pleural effusion. So he was taken by the CICU team for cardiac cath. So as you can see from the initial films, great steak and cigarettes diet in West Texas, this is what you get. Heavy calcification, this LAO-caudal projection. And then LAO-crani as well. Critical lesions in both the circumflex and the LAD with a lot of diffuse disease. And then widely open CTO of the right. So right not looking great either. Also did an LV8-gram and saw that he had an inferior apical aneurysm and grossly depressed EF. So a balloon pump was placed following the procedure, and the CIC team actually consulted the cardiothoracic surgeons for their opinion. They said due to lack of mobility, alcoholism, and generally poor condition, that they did not recommend for CABG. And so at that time, he was referred to our complex BCI team to evaluate for intervention. The surgeon also discontinued the balloon pump at that time. So we elected to pursue CSI for this patient. So here's my animation of just the CSI passing. We elected to just go for the LAD initially with plans to bring him back for the circumflex in the future. So CSI went well. We did angio post-atherectomy. Some improvement in the lesions throughout the LAD, but we felt primarily would allow us to deliver our stents and expand them well. So he ultimately required 3 stents in the LAD. Here's the 3rd stent being deployed. So then all of a sudden we had a drop in the blood pressure following the 3rd stent, 75 over 44. So in the essence of time, I won't ask everybody to reply here, but what actions do you take is really kind of what hits you next. So, our first thought was, well, maybe you're using a Viper wire in CSI. It's pretty sharp. Maybe we had a distal wire perforation. Maybe there was some complication of the procedure itself. So we took a shot, we pulled the wire back slightly, but we didn't want to lose complete position. We saw no distal wire perforation, we saw no collection of fluid around the heart, and we saw no distal bleed. We did stay on longer than this, but no distal bleed. So next thought, in these cases, we're always worried about tamponade, so we had bedside echo available. We got a stat echo. You can see in the subcostal projection, no evidence of fluid around the heart. So now we're kind of thinking, what do we do here? We got the patient on pressors. We've started IV fluids. We're considering reversing our anticoagulation. So next thought, access site issues. Do we have a problem with our access site? So we're in the left groin. Took a shot here. Everything looks good. All right. So anyone have any thoughts?
Was the echo normal?
Echo was normal. Yeah.
How about the rest of the panel?
Can you play that Andrew again? Not sure if the lateral does look a little sort of spliced to the side, but there used to be fluid there, but not don't see any fluid coming out.
So
retroperineal.
we routinely give aminophylline beforehand to combat the hypotension from the release of adenosine during atherectomy. I have not seen it present like this, but you definitely see it acutely. So I don't know if that was a concern or not. Now with the aminophylline shortage, we're using caffeine, but it's another option or another issue.
It's also more common in the right coronary artery, which is occluded. You worked on the LAD, so.
So your guide configuration, sometimes you can get severe aortic regurg with a guide pushing down the aortic valve. Was that pulling the guide back sometimes?
Yeah, we did reposition the guide, and again, on the echo, we looked at flow as well. I only, demonstrated for the sake of time the lack of an effusion.
Or delayed shock from contrast.
I'm sorry?
From delayed shock from the
Yes,
contrast.
yeah, so I think that's kind of where we were starting to think. But actually, as I leaned over to take this left shot, I leaned on the right side of the patient and noticed that he was having a large hematoma growing at the side of the former balloon pump. So he had a balloon pump removed 2 days prior, and he had late bleeding here. So then the next question was, what do you do with this? So call vascular surgery, 30 minutes. Calls cardiothoracic surgery, 2-hour response. Call interventional radiology, they get back to you 2 days later. Or do you take care of it yourself? So obviously we elected to take care of it ourselves. So we crossed over, shot the right groin, and you see perforation here. So obviously holding manual pressure at that time as well, in between getting our equipment in place. We tried to balloon tamponade for 15 minutes, but we were unsuccessful in doing so. So we have VBX stents, and these are covered, these are covered stents, and we deployed a VBX stent to control the bleed, and we had a good result.
Did you not complain of groin pain at that time?
No complaints from the patient.
That's a great case. I think it underscores the importance of also, VBX also goes to 8 French, so you had 8 French access, which is nice. So it's important to understand what your access is and what you can deliver. Otherwise, you could deliver to Biobon there, would have been fine too.
Mm-hmm. So post-procedure, the patient's blood pressure stabilized with IV fluid. Pressures were both withdrawn within 1 day. The hemoglobin dropped. It was 10 before the procedure, dropped to 7. But he did not require any transfusion. It remained stable from 7 and actually rose throughout the rest of his stay. He was discharged 3 days following the procedure. He returned 1 month later, and we did CSI to his and PCI to the left circumflex. So the takeaways from this case, it's important to be familiar with all the causes of hypotension and be able to review them quickly in the cath lab. It's important to be intimately familiar with the history of the patient. We were aware of the balloon pump, and we recognized that was the cause of this issue. And then it's important to be comfortable in the peripheral interventional space, even as a coronary operator, because these complications arise and you need to be able to manage them in case of an emergency. Thank you.
Great case. So how about, how many people would have just put a balloon up there and reversed anticoagulation and just waited to avoid putting a stent in an inflection point in the artery?
Yeah.
Why not?
Yeah, well, we tried tamponade for 15 minutes, and it was still bleeding quite profusely. So we did not reverse anticoagulation. Obviously, we stopped dosing, but I think we were, we were still a little bit nervous about the intervention itself. We didn't want to have, thrombosis of the stents early, but I mean, I suppose
we calcification there too. So I think it was probably a split of a plaque. So I don't think balloon was going to hold that. I think that was probably appropriate. But I agree with you. I would have done balloon first for 20 minutes and just also had the fellow hold for external and internal tamponade.
Right. The other thing is we tend to, patients all covered up, so you may not even look at that groin. Sometimes they cover that whole area up. So I think it's important, like you said, to try to assess the whole patient, something you might miss. Questions?
Great case. Did you think of possibly this case with dynamic support, like with an impella, because you have a patient, trivial disease, RCA is gone. And as soon as you wire the LAD, you may run into the problem of reflow just wiring that LAD. And then the patient is going to be pretty in bad shape if you don't have dynamic support. In this case, it did very well, but these things can happen, especially if you're going to do atherectomy, again, more chance for reflow. So I would say that probably if there's no issue with the access side, I would put an impella before doing atherectomy. And probably take both processes in the same session.
Yeah, one element was not accessing the groin again, you know, it was 2 days later. But we were prepared for Impella, we actually had it in the room, should we need it. But, you know, the patient's hemodynamics were stable going into the procedure. We've done CSI in a number of cases without any kind of, you know, significant requirement for support. So, so we felt comfortable proceeding without it.
The other thing is, did you guys treated her with 2B3A prior to the CSI? Or did you just use separate?
Yeah, we just use heparin.
That's good. All right, thank you very much.
Thank you.
Excellent case.